Okay, welcome. So we just wanted a quick, another quick nugget, third one for Geeks 4. Look at this huge thing in the rectum, and you might immediately look at this and think, oh well, that's cancer. Patient's got to have a proctectomy, because we're right down on the anal verge here. But as we go in, it's a little bit of fluid around, a lot of mucus around, because it's a very villous mucus-producing thing. But when you look over the surface, you don't really see anything. Nothing's catching your eye as if it's unstructured. And actually, when you keep on looking, you can't really see anything on the surface that suggests that this thing contains any submucosal invasion of tumor cells. Then when we come further a bit, and potentially we want to retroflex to have a look and see the back of this thing, which you can do with a gastroscope, and you might see that someone's just started something there, but if you ignore that, then you can see that this thing is maybe about, maybe about 60%, 70% of the circumference. And we can come back through it and look at the anal verge here, and you can see that passage of normal which exists between the bits of polyp. And then you can see that it sits really nicely over the first rectal fold, maybe even the second, but it's definitely not got any surface pattern that's very concerning. So this polyp doesn't have any overt sign of cancer within it. And therefore, is it for surgery? Well, I would suspect not. I think the next thing we need to think about is what is the risk of buried cancer within this polyp, and that risk is relatively high because it's in the rectum, it's relatively big and bulky, so maybe that risk approaches 20%. So for sure this needs an en-bloc resection in one piece, not for piecemeal EMR, not in a fit and healthy patient. But that's a little bit how you can make decision making. And so when we look at the risks for submucosal invasive cancer, they first revolve around whether you can see cancer. Well, here we can't. And then the second part is, well, what's the morphology and where is the polyp? And rectal polyps with this morphology should be your go-to polyps for buried cancer under the surface, and they should be discussed with your friendly local MDT or resectionalist for consideration of en-bloc resection in the right clinical context. All right, well, I hope you enjoyed that. Another huge polyp for the preparation of everyday endoscopy. But of course, these are things that people see all the time, and that's why we want to introduce you to the way you can make decisions in these situations. Thanks for